And good morning to everyone here. Thank you all for coming. It's my humble honor to introduce our first keynote speaker of the day, Dr. Denise Basow. Dr. Denise Basow currently serves as the Executive Vice President for Ochsner Health, as well as the system's first Chief Digital Officer. In this role, she oversees all digital programs, including virtual care, remote patient monitoring, and chronic disease monitoring as well. She also oversees Innovation Ochsner, which is a venture capital arm of the organization, looking at new technology, the development of new digital health ventures, and similar companies. Prior to joining Ochsner in 2022, she had a 25-year career with the software and information giant Wolters Kluwer. She served as president and CEO of Clinical Effectiveness there, and also went on to serve as editor-in-chief of UpToDate, a website I think all of us in clinical medicine use quite regularly. So today it's my honor to welcome Denise to the stage. Thank you very much. Appreciate it. Yeah.
Good morning. It's a real honor to be here this morning in front of this group to talk about something that I have a lot of passion about, which is digital health. We are in the early-ish stages of what I think we're going to look back on and say is a handful of the most transformational times in healthcare. That's a pretty bold statement, although it sounds like you heard pieces of that yesterday. And the reason for that is that we are having a confluence of events happen that, again, we've really not seen before. So on the one hand, a lot of challenges. The cost of chronic conditions, which are really threatening to crush our health system if we don't figure out different models of care around them. Expectations from consumers, which are just really different than anything we've ever seen before or had to deal with before in healthcare. Workforce shortages, physicians, nurses, you name it, across the whole healthcare continuum, which are, again, threatening our traditional models of care. Health equity, I'm really happy to say, has come to the forefront and something that we're talking about now in ways that we never really talked about them before. That's a good thing, but it just means we have to pay attention to that and think about that as we're, again, thinking about our models of care. And then new competition. Health systems have always competed with each other, but we now have a whole host of new digital-first types of competitors, which, again, are challenging the way we've traditionally done things. Now, on the other side of things, there's tremendous opportunity. AI, it sounds like you heard a lot about that yesterday. I'm going to talk some more about it today. But really, when we think about large language models, that's what LLM is, brain-computer interfaces, but a whole host of other opportunities that AI is bringing us now. We haven't traditionally in healthcare been super fast adopters of technology, but this looks really different, and I'll talk about why in a few minutes. Genomics and precision medicine, I'd be the wrong person to talk about this. You're going to hear more about that later. But again, I think one of the more transformational technologies that are going to change how we think about care. And then finally, remote monitoring. Our ability to not only has the technology improved for us to be able to monitor patients outside of traditional healthcare settings, but what we can now do with that data to become more predictive and preventive in our care, again, really transformational in terms of how we think about patient care. Now, of course, when we talk about technology, when we talk about change, when we talk about disruption, there's usually money behind that, and there's a lot of money here. This is looking at venture investment over the last decade. The 2021 was certainly a banner year and the year we talk about for venture investment into healthcare. And while it looks like that has come down to a more normal state now in 2023, it still surpasses anything that we saw prior to COVID. And probably more importantly, this is just counting venture investment in healthcare. It really is not talking about a lot of that money that's now going to AI and newer technologies. And then it's not just venture investment. Private equity is playing, I would say sort of quietly maybe, playing a pretty big role behind the scenes in driving the healthcare landscape. What the graph on the right is showing the purchase of either physicians or physician groups by various entities from 2019 to 2023, and that very tall blue bar, about 65% of physician groups or physician practices that have been purchased in the last 4 years have been purchased by private equity. And that's more than what health systems or others have done combined. So you say, well, is that a big deal? And I'm not sure we know yet. There are some data to suggest, as this report from the Kaiser Health Network suggests, that it's not clear that this is actually resulting in good things. It looks like it may be increasing prices and having some negative effects on quality, although the jury is still out definitively. But the reason that I bring up all of these types of data is this is kind of a grand experiment in healthcare now with kind of new competition, new entries into this space, that it's not clear how this is all going to resolve itself. The other reason I bring it up is that despite all this money that's pouring into healthcare, it's not necessarily doing what we want it to do. So we're spending over $4 trillion in this country, twice the average of other wealthy countries. We know a lot of it is wasted, but what may be less well known is a lot of that money is not going to direct patient care. It's going to intermediaries like PBMs or pharmaceutical distributors or payers. And in fact, if we look a decade ago, about 25% of that healthcare spend was going to these intermediaries. It's now 45%. And we keep falling behind as a country in health outcomes. Not saying it's a direct correlation, but we're definitely not spending money in the places to turn this picture around. So even before COVID, we were falling behind. The left side is life expectancy compared with our peer countries. That's continued since COVID. And perhaps most disappointingly, the gap in outcomes between the poorest and wealthiest parts of our country continues to expand. So again, several years ago, the bottom line is death rate amongst the wealthiest parts of our country. The top line, death rate and the poorest parts of our country. And in the year 2000, if you lived in the poorest parts of our country, you'd be 60% more likely to die than at a given age than if you lived in the wealthiest part of the country. So that's a bit of the macro environment. I have a high interest, as I imagine many of you do, in seeing health systems be successful through all this disruption. And one of the kind of unfortunate things that's happened in kind of this macro environment of lots of competition, lots of technology, outcomes maybe not exactly where we want them to be, is that there seems to be a bit of an attack on nonprofit health systems, in particular, coming out of all of this. And as I said, we're kind of in this grand experiment of how all of this is going to shake out. As I suspect many of you do, have a high interest in seeing the health systems be successful in this, in part because I think we have motivations in the right place. And so in addition to having some challenges from Washington and other places, health systems are facing a lot of other challenges in this environment. And I'm just going to talk about a few of those because they provide a backdrop for why we need to continue to evolve from a digital perspective, digital and technology perspective. So with all this money that's being invested in healthcare, it's not surprising that there's lots of competition. And that competition, not meant to really read this slide, the important point is that competition is now encroaching on pretty much every aspect of the healthcare ecosystem. Now, I'm not anti-competition. I actually spent the last 25 years in healthcare IT, and from an industry perspective, competition is really good. But it's just something that we need to be mindful of, and it really is pushing us to change, and we have to change with it. In addition to lots of companies coming in, or lots of different businesses disrupting our traditional care models, our customers or our patients have changed a lot as well. We used to rely on loyalty of our patients to drive business for our hospitals and our clinics, but loyalty really isn't enough anymore. Convenience and access are becoming paramount. So this study is asked, amongst a number of other questions, in the future, which of the following will have the biggest impact on your decisions about where and from whom you'll obtain care? And 70% of people said it was the ability to obtain timely care, so the convenient appointment availability. And you can see why. If you look at the bottom, some of the taglines of some of these digital-first competitors: high quality care in minutes, not days. Home is where your health is. Open 7 days a week with no appointment required. We're one text away. This is what we need to contend with. And I had somebody at our organization who was resisting online scheduling and said, well, look, only 30% of people say that the most important factor for them is online scheduling. And I say, yeah, but look at this. For patients who prefer online scheduling, half of them would switch providers to be able to do that. So really changing consumer behavior. But here's where the rub really lies. We have an epidemic of chronic disease in this country. I will show you those data specifically for Louisiana in a few moments. But 1 in 3 adults in the U.S. have multiple chronic conditions, and that's accounting for about 86% of our healthcare spend. But here's the real problem. 3 in 4 older adults have multiple chronic conditions, and that gets even more expensive. And while in the year 2020, about 46 million U.S. adults were over the age of 65, by 2050, that number is going to double. And it's not just that we have more older adults. The older population is getting older. So if you look at the far right, the compound growth rate of people in different age categories, the 65 to 69-year-old group's only growing at a 1% CAGR, but the older groups are growing much faster. So the older population's getting older, and that older population costs a lot more. Again, focusing on the right, that's the per person, per month cost by age group, and you just see the numbers increasing pretty dramatically as we get older. And then the question is, who's going to care for these patients? I mentioned workforce shortages earlier. I won't dwell on the numbers, but we have substantial shortages in primary care, in specialty care, in nursing. And even if we had enough primary care physicians to take care of all these patients, our primary care physicians don't have time to do it. So this was a study published in 2022 that looked at a typical panel of primary care physician with a panel of 2,000 to 3,000 patients and said, how much time do they need every day to practice high-quality, evidence-based care? And it was 14 hours for preventive care, this is per day, 7 hours for chronic disease care, 2.2 hours for acute care, 3.2 hours for documentation and inbox management, and I know it's early, so I will do the math for you. That's 26.7 hours per day. So something's got to give, right? So what do we make of all this? What is the future going to look like? Well, first, we're going to move from what we do mostly today, which is episodic care, to much more continuous care. We have the ability to do this, to monitor patients and do this continuously. We're not really going to be talking about sick care. We're going to be talking about more predictive and preventive care. We're moving from generalized to personalized. We're not taking care of a cohort of patients with hypertension. We're taking care of Mrs. Jones' hypertension and her unique things, or as you're going to be talking about, precision medicine and cancer care. We're going to move from being more hospital-focused to talking about home or remote care focus. We're already doing that. And then we're going to stop being reliant on humans alone and have more AI-assisted care. Not, again, taking the place of care, but assisted, and I'll show you some of that in a moment. And underlying all of this are the technologies that I spoke about earlier that I think are really underpinning the whole transformation, which is AI, precision medicine, and remote patient management. So it sounds like you had an entire keynote on AI yesterday. I will pale in comparison to that. But I do think it's important as it relates to the types of things that we can now do in medicine, or that will be changing in medicine because of it. I do think it's worthwhile spending a few minutes here. When I'm talking about AI, I'm talking about predictive modeling or machine learning, which has been around for a really long time. Computer vision is another really interesting technology that we're doing. I won't talk about more today. We are doing some things around this, in particular with identifying when patients are moving in their room who may be at risk for falls, so that we can expand the capabilities of our e-sitters. Also, lots of application for computer vision in surgery, as you might imagine. And then large language models, which is normally what I'll call it, but another name for generative AI or ChatGPT, which is most commonly known. This was a study that was published by McKinsey and some economists at Harvard in 2022 that suggested that AI adoption could save 5 to 10% of annual healthcare spend in the country. This is, I believe, a gross underestimate, because this study was published in 2022 based on earlier data, really before large language models kind of hit the scene and are now changing everything. So why are large language models changing everything? Everything about them has been different. We again, are not traditionally great at adopting technology in healthcare, but this looks really different. It's been really fast to develop. When GPT-2 was first published in November, or first started being used in 2019, it had about 1.5 billion machine learning parameters that it was trained on. 6 months later, it had been trained on 175 billion parameters. We think that number is closer to 1 trillion today, but nobody's really said for sure what's happened with GPT-4. And of course, by February 2023, it had passed the USMLE, the medical student licensure exam. So speed of development, speed of adoption. I don't know if this was shown yesterday, but this was the time to reach 1 million users. Netflix was over 1,000 days. ChatGPT was 5 days. This has now been surpassed by, I'm not a social media person, something called Threads. I had to actually look it up. It's Meta's version of Twitter. That actually only took a day. Anyway, huge adoption quickly. Speed of learning. These are a variety of tests ranging from AP high school tests to the bar exam to various other types of medical tests, so the whole gamut. The important point here, you don't have to read the details. I can't even see them on my screen, but the important point is that the blue is GPT 3.5, which was kind of for OpenAI's first launch of this publicly. That's the blue. The green is the next iteration of GPT-4, which again wasn't that much later, and you can see how much better it did on all of these exams in a very fast period of time. We just have not seen anything like this. And we're now starting to get other data on how these things are working, just from a productivity, quality, those sorts of perspectives. This was a study that was published last year that looked at answers that physicians gave to medical questions that were posed in a social forum, looked at answers that the physicians gave against answers that ChatGPT gave, and then had an independent reviewer the independent reviewers preferred the chatbot responses 79% of the time to the physician responses, and those chatbot responses were viewed to be more empathetic, almost 10 times more than what the physicians did. Now, I was showing this study to somebody the other day, and they said, "Oh, aren't you afraid to show that to a room of doctors?" And I use the principle that if you're in the same demographic, you bash your own demographic. But really, this is not actually doing that. It makes perfect sense. Like if you go into the details of what some of these questions were and what some of the answers were, when the patient says, there was one patient that had an upper respiratory infection, and physician wrote a very good response. This is what you should do for an upper respiratory infection. ChatGPT starts with, "Oh, I'm so sorry you're feeling ill." It has all the time in the world. We have no time. So it makes perfect sense. But I think it's actually an important insight, again, to say where some of these things can start to be useful. But this is probably one of the more interesting findings about large language models, because again, really different than anything we've seen. So this has been a compilation of studies that have looked primarily at productivity of workers in a variety of fields. So customer support, writing business documents, programming, nothing to do specifically with healthcare, but just across the board. And I think, again, some important insights. And people in all of those areas have become more productive, and especially my youngest daughter is a software engineer, and I keep telling her maybe we need to go and think about ways to expand your knowledge base there, because this is really changing that field in particular. The workers are becoming 120+% more productive using large language models. But that's not the most interesting part. The most interesting part is that normally when we introduce new technologies, new automation types of technologies, robotic process automation, other things that make people more productive, quality typically goes down. That's just been historically what happens. Not here. In this case, not only did productivity go up, but quality virtually always improved. So really different. Also, the next insight is that it's really narrowed the gap between the worst and the best performers. So it's the worst performers or the most inexperienced people who are benefiting the most. And we saw a really stark example of this. I'm going to talk about inbox messaging a little bit later. But when we implemented ChatGPT to help answer inbox messages, it dramatically improved capabilities of our less experienced nurses, but we gave it to one of our most experienced nurses, and she hated it. It made her less productive. So again, really interesting insights for how we can begin to use this technology. And then it can dramatically accelerate the learning curve. I was talking to our chief nursing officer the other day, and we're hiring nurses like crazy, like most of you probably are. But it's really hard to hire experienced nurses. They're all leaving the workforce. We're hiring really, new, right out of school, inexperienced nurses. And the ability to accelerate their learning curve is going to make a tremendous difference. So then people say, what about clinical decision making? It's beginning to show some promise. Your studies have been looking at clinical decision-making augmented by large language models, and some accuracy in diagnosis, but still making too many mistakes for it to be ready for prime time. Whether it's errors in medication dosing, recommending unnecessary testing, recommending the wrong thing. But the real problem is it still really makes things up. So you sometimes hear this called hallucination. It's getting better, but it's still making things up. In the study on the right-hand side, and there were inaccuracies in references in an article written by biomedical article written by ChatGPT, made errors in 93% of the references. Maybe we all make errors in references, but 47% of the references were completely made up. And I'll show you an example of this. This is pretty funny. I mean, it's not funny, but it's funny. So these investigators queried ChatGPT about engorged female hard ticks and where they might choose to lay their eggs. And ChatGPT said, well, in one study, researchers found that they can travel several hundred meters before selecting a suitable site. And the investigators were like, really? We'd never heard of that before. Do you have a reference for that? And very confidently, that's the thing, is even when it's wrong, it's very confidently wrong. Very confidently, ChatGPT cited a reference, gave a link, they clicked on the link, it was a dead link. They called the authors of this, the first and the third author of this study, and the authors had no idea where it came from. Nothing to do with it whatsoever. So still, there are some clinical applications, and we'll talk about those, but still need to be careful. Now, we're not just talking about large language models here. There's good old-fashioned machine learning models that are still incredibly effective. This was a report published last year. I think these are really interesting use cases for machine learning models. In this case, trying to increase the group that would be relevant for pancreatic cancer screening. We can't screen everyone, but if we can increase the number of people for whom screening is relevant, we can save lives. And in this case, the model increased by about 3.5-fold the number of patients who screening was relevant for. So lots of reports. I could show you 20 of these, but so lots of still really interesting use cases. And then this technology is also now marrying with our ability to remotely monitor patients or to diagnose things differently. This is a company called ResApp. You download their app on your phone, cough into your phone, and it can identify pretty well whether you have an upper respiratory infection or pneumonia. This is a cool one. This is a company in Israel called Bina.ai. It uses a really old technology, actually, called photoplasmography. You look into an app on your phone, or you look into the camera on your phone with this app, and it can measure blood pressure, heart rate, oxygen saturation, and starting to measure blood tests like hemoglobin A1C, cholesterol. Very cool stuff. This one I was less familiar with, but this is super interesting when we talk about upskilling our workforce or lowering the gap. This is a device that sits on your stethoscope and allows you to detect heart failure, AFib, and valvular heart disease. This is actually being tested in a pretty large proportion of the UK now. The UK system, they have a lot of GPs, which are essentially you finished medical school but haven't done a residency kind of thing, so pretty inexperienced clinicians. And they're seeing if we can use these to help them avoid having to consult a specialist. And then the last example I'll give here, this is a device that just received FDA clearance that allows you to take look at skin lesions and have a much better diagnostic capability to identify cancer or something that is more risky for cancer. Again, if wait times at your hospitals are like ours, it's really hard to see a dermatologist. Again, trying to bring up the level of less skilled clinicians. Okay, so I'm going to spend the last 10 minutes or so talking about some of how we're taking a lot of this stuff that I've described in the macro environment and bringing it to life at Ochsner. So most, if not all of you, are from Louisiana. I don't have to describe if there's an epidemic of chronic disease in the U.S., we're seeing it as bad or worse than anyone. This map is showing diabetes deaths. Dark is bad. But the real challenge is that if you add together the patients in this state who have diabetes and the ones who have prediabetes, it's about 50% of our population has one or the other. Similar map of hypertension, but the real issue with hypertension, obviously the prevalence is a problem, but the real issue is what's in the gray box on the left-hand side, which is not unique to Louisiana. This is a U.S. problem that even when we know you have hypertension, even when we are treating you, so forget the ones we don't know about or we aren't treating, but even when we know you have it and we're treating you, we're only successfully treating you about half the time. Big problem, and have not moved the needle on this in a decade. Now, the other, one thing to know about Ochsner is that we have really leaned into value-based care. We have about 700,000 patients who we are taking some kind of risk on, not necessarily full risk. We are on some of them, but we're taking some kind of risk. And why does that matter? Why do I bring that up? Because it provides a really interesting environment for innovation and trying new things. We have to. It is really hard to innovate in a fee-for-service environment. There's absolutely no incentive, and at the margins that we operate at, there's just no money to do it. But in a value-based environment, in a value-based environment with the amount of chronic disease that we take care of, you have to do things really differently. So one of the ways that we have really tried to innovate is around chronic disease management and really thinking differently about those care models. We call it not remote patient monitoring, or remote physiological monitoring, which is what RPM typically stands for. I've managed to get the name changed in our organization to management because we really think about it in a different type of care model. So for our patients with diabetes, hypertension, hyperlipidemia, expanding in other areas, we've built a care model that is based on four things. So definitely remote monitoring. We give our patients Bluetooth devices that connect to an app that we've built that sucks in that information so they don't have to do any work. We give them a health coach. We're actually now building out a lot of our digital coaching content, and we've studied this, and our digital coaching is as effective as our live coaches. We're not eliminating our live coaches because there's still some use cases around that, but it's interesting that the digital coaching is equivalent. We manage their medications entirely outside of primary care. We connect back to primary care, but we have pharmacists. We operate this in about 40 states. We have pharmacists who can do most of the medication management. In a couple of states, they require either an APP or a physician, but largely we're able to do this with very well qualified but a less expensive care team and really take that burden off of primary care. And then we provide whatever technical support is needed, although honestly it isn't much. So why does this work? And I'll show you the data on outcomes in a moment. It works in part because we're just getting a lot more information. So we're moving from getting 1 to 4 readings per year, per year to that many readings per week. That moves us to that real continuous kind of clinical interaction because we can interact asynchronously through the app. Adherence to caregiver adherence to medication guidelines. Super interesting here. Our pharmacists never deviate from the guidelines that we've built for them, whereas physicians deviate all the time. And again, why does that happen? Well, it's imagine this: you're seeing a patient, blood pressure's high, and they say, "Oh, I was rushed getting here. I had to run in from the parking lot. I think really my blood pressure's okay. I'm just a little stressed right now." "Oh, all right. Well, we'll get it next time." Well, when you're measuring it continuously, and when you've got pharmacists who are really focused on this is all they do, we get this right most of the time. We've seen better adherence to medication regimens on the patient side. We've been able to change behavior, and I'll show you in a moment, lowering the cost of care. And so if you go back to when I said, how is care going to look different? We've really tried to follow this model of more continuous care, being more predictive and preventive, personalized, remote focused, and what is AI assisted here? Well, now we're collecting lots and lots of data from these patients. So, 1 to 5 readings per week. And we're able to use that data now to be more predictive about who may need help, who's likely to fall out of control, and a whole bunch of other interesting insights that we're just starting to be able to take advantage of. And outcomes have been pretty remarkable, and this is not just a 6-month pilot. We've been doing this for 7 years and growing our patient population. We've looked at this in all different types of demographic groups, but if you put all of them together, we get about 80% of patients under control within 6 months. That has, we don't exactly know why we're reducing cost of or utilization of high-cost settings like the emergency department and hospitalization, although my hypothesis is that we're just having a lot more frequent interactions now, so patients are less likely to default to going to high-cost settings of care. But nevertheless, we're reducing utilization, which is reducing the total cost of care, which is what you see in the lower left-hand side here. That's a per member per month savings for these patients. And this is net of medication costs. Our medication costs actually go up because they're actually taking their medications. But because we're saving utilization in other areas, we're reducing cost. And then patients really love it. The Net Promoter Score is something that we use to measure patient satisfaction. It's really rare to see Net Promoter Scores in the 80s. You see some other companies that get there, but our patients really love it. And this is only as good as its adoption, and it's not good enough. Having an innovative care model is fun, but it only works if patients adopt it, and they really have. We lose very few patients from this program. Now, this is probably the most exciting piece of this is that it works in really diverse populations, and actually works even better. So we engaged in a Medicaid pilot that was supposed to be about 1,000 patients. This says 4,400. We now have over 5,000 patients that we have been monitoring, some of them for 2.5 to 3 years, some of them a little bit shorter. But we're seeing the exact same results in this population. And in fact, sometimes even better, our highest net promoter scores are in the Medicaid population. So the light green, the left is hypertension, the right is diabetes. The light green is patients in our remote monitoring program. The dark green are all the other patients that we're monitoring. And you can see our ability to achieve control with this program from 3 months up through 18 months. this is particularly meaningful to me. I've always hated when we called patients non-compliant. That always felt a little pejorative to me, but what this program is showing is that for patients that we've traditionally had difficulty engaging, it's kind of cliche, but if you meet them where they are, if you provide healthcare in a way they can consume it, so we don't make them leave work, find a ride, to come to the doctor, but we meet them where they are, they actually care as much, if not more, and really engage in their care. So the last few things I'll talk about are just how are we leaning into AI-specific use cases at Ochsner, and we aren't shying away from, we're doing both some operational things and some clinical things. I'll talk more about the clinical pieces of it. Again, our traditional old machine learning models still work. This is one that we implemented around sepsis. We had a sepsis risk-adjusted mortality problem. It was interesting because we've had this sepsis model running to try to predict which patients had sepsis. We had this sepsis model running for years, like at least 4 or 5 years, but still we had a risk-adjusted mortality problem. And then we did something different, which is the point of this slide, which is it's not ever just about implementing the technology. It's always the process and the people you put around it. The success of this model relied on our nurses getting notified that the model found a patient at risk, and then ordering a lactate and following the other algorithm that we had set for them. But our nurses are really busy, and they're overworked, and they didn't have time to do it. So we we have a pretty big virtual nursing group, and so we called it our E-Rapid Response Team. We dedicated a nurse really just, I think, 7 or 8 hours a day, not even 24 hours a day, to look at all the patients for whom the alert fired and go through the protocol that we had set. And guess what? The number of times we followed the protocol increased pretty dramatically, and our risk-adjusted mortality has been declining dramatically. So again, it's not, we talk a lot about technology, but it's always the other pieces you put around it. From a clinical perspective, we're also leaning into using AI to help us in the radiology area. So this is a company called ADOC. We've implemented their software in one part of our organization just to try it out, and for one disease state, stroke. So anytime we have a suspected stroke in that hospital, patient gets a CAT scan, that CAT scan goes to ADOC immediately for the AI to read the study, and not to, even though our ED docs get that as well, but the idea is not to replace the radiologist reading it, but to help order their work queue. So if ADOC suspects there's a stroke, it immediately goes to the top of our radiologist work queue. And of course, we had to implement some workflow around that as well. And while I don't have it here, because I literally just got this data 2 days ago, our door to needle time for interventional radiology decreased at this one site where we've implemented this from 99 minutes before we started to 69 minutes. So this is now something that we're going to scale across the system. The other thing that we're leaning into pretty heavily, which isn't what I initially thought I'd be spending my time doing at Ochsner, but really trying to make work easier for our workforce, trying to deal with the burnout and shortages we have. And what are the 2 things that physicians hate? They hate documenting, and they hate inbox messaging. So we're working hard on those. We just went live with a small number of physicians with ambient listening. For those not familiar, you have a normal patient encounter, you sit and talk to the patient, but instead of needing to document while you're seeing the patient or afterwards, You've got, we're actually testing 2 different vendors for this, working in the background, listening, using actually large language models to then transform that information into a clinic note almost instantaneously. So this has been, again, we've just started with this. The learning curve has been almost nothing. I thought it would take at least a couple of weeks. Within a day, the physicians have figured this out and are seeing pretty dramatic improvements to their quality of life. And then I will finish with inbox messaging. We're doing a lot around inbox messaging, trying to make that better. But one of the more interesting things we've done is to try to use ChatGPT to take a first crack at answering the messages. Of course, all those, we never send anything out without it being reviewed first, because it still does make things up. But I alluded to this earlier, but the ability for our frontline nurses, whether MAs, LPNs, to answer messages. Previously, they had been able to handle about 65, 66% of the messages without them having to go to the physicians. They're now handling close to 90%, which to our physicians feels like they're almost getting no messages. So we're doing a bunch of other work around it, but this is, again, the promise of what this technology has to offer. So I hope I have taken you away from talking about cancer for the most part for the last 40 minutes or so. Hopefully that's given you a bit of a view of what's going on in the environment and how we're bringing some of those things to life. Old quote here, but it's more important than ever that we adapt to what's going on and that we change with what's going on. Again, not something we all like to do, but in this case, it's really paramount and just a huge opportunity to change care models and to take better care of our patients. So thank you very much. Oh, sure. Wasn't sure if we had time or.
Regarding shortages in healthcare providers, as a troop in the trenches, I find it's harder for us in traditional healthcare roles to compete for talent with industries that give us support. And it's not simply compensation; it's quality of life at work. It's the support you get on the job. It's the things that reduce burnout. Any thoughts on how we could adapt our system to make that easier for us?
Yeah, I mean, as I alluded to at the end, when I first came to Ochsner 2 years ago, it was not about making work easier. And now actually on Tuesday, I'm speaking to a group of HR professionals with our Chief Human Resource Officer, and we actually have a slide that, presents us as strange bedfellows, because now a good part of what I'm trying to do is make work easier for our clinicians and everyone else in the organization, really. So, there is still, if somebody's motivated by money, we're not going to compete. Like that's the way it is. But I do, I've told our organization, between things like ambient listening and inbox messaging, we are this year, 2024, not, in the next 3 to 5 years, we are this year taking away the things that they hate the most about practicing medicine. And then I think that there are other, there are all sorts of things that I'm not expert to talk about, but I think that the initial incarnations of a lot of this technology, we can actually make big improvements in those types of things. Now, whether that still solves the problem, obviously there are a lot of other, other factors. But I really think that we're going to make a huge difference this year in with these technologies.
I'm curious, where are you scaling it? Like, where are you testing? What clinics are you doing AI and the in-basket messaging? And when do we get it in specialty? Because I'm excited.
So we start where the fire is. So we're starting primarily with primary care, because and other primary care specialties, pediatrics, OB, et cetera, because that's where the fire is burning the hottest right now. But because it's not always about the technology, we tend to go where we've got willing partners to, disrupt care models and, those sorts of things. So we're still trying to prove out, what's the balance of having a well-trained nurse and the AI, and what's the optimal model there, and should it be pools of people or in the clinic? And so I think there's still a little bit of testing of that to do. But once, and the only reason that that's important is for the kind of less than early, the next wave past early adopters, we want to make sure that we've got the model right so that we don't discourage them. But we'll be ready to expand to specialties probably to beyond primary care within the next quarter or so. We do have some limitations of that. That technology comes directly from Epic, and it actually requires a lot of space in the cloud for them to be able to do this, and so we do have some limitations on numbers, but we're working through all of that.
I applaud you. Great talk. As a shameless plug, end of the day today in the lung section, I'm going to talk about a solution. We're trying to bridge that gap between survival and rural populations using some of this kind of technology and a different approach. From a hospital system standpoint, it certainly takes the leadership's willingness to do this. It also takes money and gambles of which one do you pick up, which technology to go for, which one are you going to test. How have you all been able to allocate budgeting for that?
Yeah, so your first comment about the leadership is really critical. I was chatting with our CEO last week, and he said, "How can I help you?" And I said, "Well, actually, the most important thing you ever did was make digital and technology transformation one of our, 4 key priorities, because that gave me and access, because that gave me a lot of the kind of air cover I needed to be able to go in and say, this is why we have to change." So that I don't want to dismiss that. That leadership becomes really important. As far as money, what I would say is there isn't, as you know, a lot of money sitting around. But there's a lot of waste in health systems, and we have been pretty scrappy about going around and finding things that we could stop doing. Now we've had as Dr. Matrana mentioned, we've had this program called Innovation Ochsner for many years that long preceded me, where there was some level of investment every year. But we have been able to go, where we were spending money there, where we were spending money in other areas in telemedicine and virtual care. We've just gone through and really just been very ruthless about, don't need this vendor's too expensive. I had one when I think in my first month at Ochsner, we were paying this one vendor $1 million for it. It doesn't matter what it was. And I said, I don't know what value you're bringing. I'm just going to stop the contractor. He's like, you can't just stop working with them. We've got this pilot, whatever. I'm like, okay, fine, I'll pay you $75,000. And we did. So, coming from the outside vendor world, I have a little, I have some insight into how they think about things. But I just say that to say there's enough waste in the health system that if you're creative about where you can find it, you can, that's how we fund a lot of what we do. Even with some of the virtual nursing and things that we're doing, we've taken nurses who we were otherwise going to lose because they can't work on the floor anymore, and we've been able to turn them into virtual nurses because they are capable of doing things virtually. They just can't thrive in the rigors of floor nursing anymore. And with that program, we can actually now amplify what the nurses on the floor are doing. So we've been able to kind of build business cases around that. So there's not a single answer. It's about being really rigorous with business cases. It's about being scrappy about where you find resources. And it does take some investment, but it's not taking as much investment as it might seem. Sure.
So the remote patient management. Thank you. So the remote patient management makes a lot of sense to me from a dollars perspective for patients who the system is at risk for. For patients who are under more traditional payment models, have the payers engaged with that model, or is this a potential opportunity for advocacy groups like CAGLA to help?
It's a huge opportunity. So there are codes that you can drop for remote monitoring, but it's like a square peg in a round hole. The codes require that you get like 16 or more blood pressure readings per month, which just is clinically nonsense. And so there are vendors out there that have built programs for this that are designed to get 16 readings a month and bother the patients, and we've just said it's not worth it. So we don't drop codes at all. There is not to bore you too much, there is work going on in Washington now. We have somebody on one of those groups trying to change the codes. And we were hopeful that was going to happen in 2025. It looks like that's been put off. But there's a real mismatch of what we're doing and the recognition of what it's worth from a payer perspective. So that's the long answer. The short answer is when I made the comment about how it's really hard to innovate in a fee-for-service environment, this is one example of it. Now, I am having I am talking to a lot of other health systems about this, because a lot of health systems that have been predominantly fee-for-service have not been able to lean in here. But Medicare Advantage is growing dramatically. So even systems who didn't think they were in value-based care, everybody has a growing population there, and aren't necessarily prepared for it. So I think the demographics are working in our favor. Government has not caught up yet. Oh, one more.
One last question.
You thought you had the last one, Mark.
Very last one. Thank you very much. That was wonderful. I was speaking with a colleague this week who is doing one of the test sites for the ambient listening, and just as you said, he said it really works amazingly well. So it's very real. The question is with privacy. A lot of times patients will share stuff with their physicians that they don't necessarily want in their records, or they want to be private and share important information with us. How can you keep these ambient listening systems from capturing information that the patient doesn't want in there? And is that also an opportunity for CAGLA to kind of look at some of the privacy laws around some of these things?
Yeah, so a couple things there. First, we consent patients before we engage in these encounters, so they know. And we've had some patients who have said they didn't want to be recorded, and that's fine. We also have been doing surveys of patients afterwards, and I think 98% of them have been really happy with it, because they feel like they have their doctors back. They're looking at them. And when we look at data from other organizations, in general, patients actually like seeing the words that they said in the note. They feel heard. So I'd say it's overwhelmingly positive. And we do consent patients. And then we also have the ability to edit the notes. It's not like, that necessarily has to stay there. And then we have agreements with the providers about how long they can keep the data and those sorts of things. Despite all of that, yes, it's a potential issue that that we need to deal with. And like as one example, we're probably not going to implement this in behavioral health anytime soon. It's a real challenge even in pediatrics, and so there are some specialties where this might be, it's not going to be a one-size-fits-all. It's going to be a little bit tricky. But yeah, I do think that, it's not just for ambient listening, but for any of these large language models. They sound great. I didn't go into all of the governance and controls that we're putting around this, which is substantial. And so I do think that the government is trying to wrestle now with what happens to all of this data, who's allowed to keep what, those sorts of things. And I would rather have that be something that was regulated versus we have to fight for contract by contract. So I think there is a place for understanding that and thinking about that differently.
Great presentation. Thank you, Dr. Basow.
Thank you.